Shall we start? My name is Moheb Boktor. I'm one of the gastroenterology faculty, and I will be speaking about between the diet pill and surgeon's plate endoscopic therapy for obesity. My objectives, I will point out introduction, and then I will talk about endoscopic bariatric therapy, and I will end up with comprehensive approach for treating obesity. I have no disclosures related to this topic. So, what is the definition of obesity? There are multiple definitions out there, and we can use part of every definition, but we can have a short definition or we can have a long definition, and we can try to see how we can solve the problem based on this definition. For example, the National Health of Nutrition Examination, they define obesity as the amount of excess body fat at which health risks. On the other side, Obesity Medicine Association, they define obesity as a chronic, relapsing, multifactorial neurobehavioral disease in which body fat promotes adipose tissue dysfunction. And they go on and on. And, the difference between short definition or big definition, nothing really major. It's all about how you can identify the problem and how we can solve it. So, definition is helpful, but it's more of a broader term. So now we need to get an objective thing that we can look at and we can say, this patient is obese, or this patient needs treatment, or this patient needs just to monitor. So a lot of people are using the body mass index. And the body mass index, as much as we use this, it doesn't include every patient. So that's why it's important to understand the definition for obesity, because some people may have normal body mass index, but they have other issues. However, this is the most objective thing that we can look at when the patient comes to clinic. So BMI 18.5 or less, we call this underweight. 18.5 to 25, we call this normal. 25 to 30, this is overweight. More than 30, this is obesity. And a lot of people, they classify obesity into class 1, 2, or 3. Class 1, BMI 30 to less than 35. Class 2, 35 to 40. Class 3, more than 40. So, having said this, that's what you will put your patient in one of these classifications. If you feel your patient is overweight or obese, or if you feel your patient needs treatment. What are the statistics we have? Obesity is an epidemic. It's growing so fast. 1/3 of adults in the US, they are obese. 36.5%. 17% of children or youth, they are obese. 48% of Black population are obese. Second to this is Hispanic, 42.5. And third is non-Hispanic whites, 34.5. So it's a problem, and it's growing too fast. Women are more than men. And why obesity is a problem? Because obesity-related comorbidities is growing as a big issue out of obesity. Many things, heart disease, stroke, type 2 diabetes, cancer, gastrointestinal problems, many things are coming out as a complication or as a result of obesity. So let's look to the prevalence we have in the US. That's from the BRFSS data, came out in 2015 of prevalence of self-reported obesity. The darker the color, the more obese are the population. Sad to see that 4 states having more than 35% obese population, and even more sad to see that our state is one of these four. So you can see Louisiana, Mississippi, Alabama, and West Virginia are the four states with more than 35% prevalence in obese population. Of course, it's more lighter color in the West, more darker color on the East. If you compare this with the data from 2013 on the left and 2015 on the right, you can see more lighter color here in the left in 2013, more darker color in the right, and these data from 2015. What are the predisposing factors? There are multiple predisposing factors: genetics or epigenetics. Epigenetics is basically the phenotype expression. It's a heritable changes, but without any changes in the DNA. So it follows a certain phenotype without changes in the DNA itself. Environmental factors, psychological factors, and psychology mainly depends on the culture that we are growing at. What type of food they make, how, the certain diets are changing within this culture. And we are seeing a lot of environmental and psychological factors lately compared to before. So I put this slide out of up-to-date to show you how complex genetics are in the picture of obesity. It's very complex. There are many genetics we know and many we yet don't know it's involved in this. And it's hard to understand all the mechanisms, but it's very complex. So knowing the definition and the statistics, what we have available for treatment. We have lifestyle, pharmacotherapy, or surgery. And I left one box empty, and I will tell you why. So lifestyle include diet, include exercise, include behavioral therapy. And pharmacotherapy will touch base about the FDA-approved drugs and surgery. So what about diet? There are multiple diets out there, and I picked up a sample of these different diets. There is an Atkins, which is low carbohydrate, LERM, low fat, Mediterranean, moderate fat, Paleo, high protein, Predkin or Ornish, very low fat, South Beach, moderate fat, and Zone diet, which is high protein. So is there any diet superior than the other? Multiple studies were done in the past by Wadden et al. Also, Foster et al. Presented multiple data in New England Journal of Medicine. You can go back and read about this. No diet is superior than the others when it comes to weight loss. However, here are the 2 points we know about diet. We are, as physicians, the majority of us, we are not capable to handle this issue. So out of all the studies, out of all recommendation, a lot of people, what they recommend, to refer those patients to a registered dietitian to help you with diet. They have the up-to-date knowledge, and they have the time. Many times, one visit can take from 1 to 1.5 hours to sit down, talking to the patient about diet, what can he do, and what he cannot do, okay? That's number one point I want to point out here. Number two is we are going towards the direction of individualization of diet. So whatever diet can be fit for me may not be fitting someone else. So individualization and registered dietitian, this is the way to go when it comes to discuss diet with these patients. But in general, you say, give me a single point I can talk to my patients about. If you want to talk to your patient about diet, the most important point is calories. Talk to your patient to cut down on calories. This is very important point to discuss with your patient in clinic. So, once the studies were done, how much calories the patient need to take at the time of weight loss and down the road for maintenance of weight loss. In the intervention of weight loss in women, the limitation 1200 calories, in men 1400 calories. And after they reach to the point with a good BMI, they already have lost good weight, maintenance is 1400 calories for women, for men is 1800 calories. And a lot of people nowadays, they point out toward calories as a single most important thing you can make for diet. However, what I recommend to refer those patients to registered dietitians. What about exercise? A lot of people refer those patients to personal trainers. However, we don't have this luxury in many of our clinics. So, recommendation is for the intervention of weight loss, more than 150 minutes per week of moderate intensity exercise, more than 10,000 steps a day. Of course, if your patient is having a heart disease or any other issue, you may need someone to help you with the exercise. What about the weight maintenance phase? Is 200 to 300 minutes a week of moderate intensity. So with the exercise, you need to add extra to maintain the weight loss. Behavioral modification. This is one of the aspects that was ignored early on when people were discussing weight loss. However, in the last few years, it's becoming more prominent. It's actually very important. It's one of the cornerstone for lifestyle change. Why? Because the patient may follow all the instruction, but still missing one of these issues that can change the picture of his weight loss. For behavioral modification, we normally recommend to refer those patients to psychologists or psychiatrists to help with this. Again, we are not well equipped as physicians to go over these points. Some centers, they are using a behavioral coach, but again, that's an extra for your program. And what he will go over self-monitoring, problem solving. Those patients will face a lot of issues down the road, either in the intervention or in the weight loss phase. Stimulus control, what the patient can do when he is on weight loss program and he can see a good meal, or he went for a dinner with friends at work and they have good food, or when he goes to the place where they serve his favorite drink that include high calories, what can he do? Social support, cognitive restructuring. So many times we need to restructure how we think about things in order to keep going with the weight loss program. Relapse prevention. And that's actually very important last point, because some of the patients will do well and then they will come to a point where they will start to have relapse. How can they avoid this? So that's what we call behavioral modification. And Wadden and Klein et al. Did a lot of good publication about this. So let's move from lifestyle to pharmacotherapy. There are 5 FDA-approved drugs out there in the market. And normally, we let the primary care to handle those drugs unless you feel prescribing those drugs for your patient. They have orlistat, which is a lipase inhibitor. It can cause diarrhea and fecal incontinence. Locastrin, it's 5-HT2CR agonist. And the side effect, headache, dizziness. And of note, it can cause valvular heart disease or valvular heart damage. Phentermine and topramate XR. It's norepinephrine and DOPA reuptake inhibitor, and the other one is GABA reuptake agonist. It can cause headache, paresthesia. In pregnant women, it can cause cleft palate. We have papropion SR and naltrexone. It can cause headache, insomnia, constipation, tremor. And the most recent drug approved is liraglutide. If you prescribe this medicine for weight loss, it's called Saxenda. If for type 2 patient, the most common that we all know, Victoza. So if your patient has type 2 diabetes, it will be more cheaper than Saxenda. And it can cause diarrhea, nausea, and one of the side effects, pancreatitis. All these medications are FDA approved, and all of these medication has 5 to 10% chance success for weight loss. Of note, lifestyle modification, it has 3 to 5% chance for weight loss in all the patients. What about bariatric surgery? Bariatric surgery is the most efficacious way or method for weight loss. However, not everybody can get bariatric surgery. We have restrictive surgery, we have malabsorptive, or we have restrictive malabsorptive. As y'all all know, Roux-en-Y gastric bypass is the most commonly used now. Excess body weight loss up to 70 to 80%. However, all the surgeries, they have complications. Rank between leak, bleeding, structure, morbidity, mortality, and macronutrients deficiency. So surgery is efficacious. However, as I will talk later on, only 2% of obese patients can get surgery, and I will explain why. So now we talked about life, we talked about all the available therapy, we talked about lifestyle, talked about pharmacology or pharmacotherapy, and we talked about surgery. There is a big gap between pharmacotherapy and surgery. How can we fill this gap? So in order to think about filling this gap, we are looking for an intervention that is efficacious, high efficacy, but low risk. We know that bariatric surgery is the most efficacious procedures. However, they have a high risk, while lifestyle and pharmacotherapy, they have a low risk, but they are not effective. As what I mentioned earlier, 2% of the patients of obese patients are going to receive surgery. That's partly because of the complication. Other side of it, insurance problem. A third problem that can happen is these procedures are permanent. So there is no room for revision if the patient down the road wants to get rid of this procedure if he develops any side effects. Strict indication is one of the problems that facing insurance company in treatment or in having bariatric surgery. They recommend BMI of 40 or more, or if you have BMI 35 to 40 with one of obesity-associated comorbidity or failed non-surgical treatment. And in addition to strict indication, complication is one of the problems that driving the patients away from having surgery. So how can we fill this gap? Endoscopic bariatric therapy. So this procedure, endoscopic bariatric therapy, if our senior faculty here back like late 80s, 90s, there were some procedure out there. There were a lot of complications at that time, and some of these procedures were stopped. However, the ideas itself were good. How they thought about the intervention was a good thought, and these companies tried to adapt the ideas with newer models of endoscopic bariatric therapy to improve the product and get something with less complication rate. So they didn't come up with ideas out of the blue. They depend on surgery and other intervention in order to come up with the idea for endoscopic bariatric therapy. So we are looking for a change in anatomy, how we can change the anatomy in our GI tract in order for the patients to lose weight, in physiology, and the hormones in our body in order to help the body to lose weight. So we have three areas we can look at, the same areas that the surgeon are performing their procedure: restrictive, malabsorption, or combined procedures. So the endoscopic procedures are looking into three aspects: either space-occupying devices, gastric remodeling, or small intestine procedures. So what we have as a space-occupying devices? We have intragastric balloons, and we have other devices. We have reshaped balloon, which is two balloons, two independent balloons, with a bridge in between. And they thought about the idea of two balloons in case one of the balloon is going to deflate, the other one remain inflated, and it does not cause any problem. On the other side, we have the Orbera, which is one balloon made of silicone, inflated with saline, and the risk of migration is very low in these balloons. So both of them approved. In fact, Orbera approved in August 2015, Reshaped approved in July 2015. The recommendation in the US, BMI 30 to 40. However, when the clinical trials were done for Reshape require one of obesity-related comorbidity as one of the indication. We filled the Orbera with 400 to 700 cc of saline, and sometimes we add methylene blue in case the balloon will rupture. This will turn the urine into green, and the patient can detect the methylene blue in the urine early and can come to you if the balloon rupture. The recommendation in the US, the balloon to be there for 6 months. However, the program need to be there for 12 months. So even if you will place the balloon at time 0, patient can come to you or will come to you to take the balloon out at 6 months. Still, the patient need to be followed for 12 months total. And we expect that the weight loss is around 10 to 15% out of these balloons. What are the contraindications? Prior gastrointestinal surgery, and with this contraindication that is in place in the US, there was no single case of perforation in the US from all the data out there so far. In the past, a lot of people, they use the balloon in people with prior gastric surgery. FDA put this as contraindication in the US to any prior gastric surgery. If you have a large hiatal hernia, makes sense, the balloon will sit there for quite a bit of time. If you have a bleeding disorder or hypercoagulable state, liver cirrhosis, pregnancy, or gastroparesis. And the point of gastroparesis, remember, these balloons does not only work as a space-occupying lesion, it actually induces some gastroparesis in the stomach. So these people will have some symptoms of gastroparesis, and I will talk about the side effects. So what are the adverse events we see? We see abdominal pain in 33%. In fact, it's more abdominal cramping in these patients. Nausea, and the abdominal cramping and nausea are coming from the idea of it induced some form of gastroparesis. And sometimes, in fact, we ask the patient to lie down on his left lateral position to help the balloon to reposition if he has a lot of symptoms of nausea and abdominal cramping. And those are the two most common complications or adverse events were noted in the studies. Early balloon removal up to 7.5%, balloon migration 1.4%, and GI perforation less than 0.1%. And to my knowledge, there is no single case in the US of balloon perforation. So what are the data out there about weight loss? Orbera in the meta-analysis of 12 months total body weight was 11.2%. 12 months excess body weight 25 to 32.1%. That's for Orbera. Reshape excess body weight is almost comparable to Orbera. The Reshape balloon had a 10% incidence of gastric ulcers at the time of removal, but there were no major side effect, no major bleeding, no major perforation from these gastric ulcers. And the studies showed that in Reshape balloon, 66% of the patients were able to maintain the weight loss for 12 months after removal. So reasonable results, more superior than lifestyle and pharmacotherapy, but still, less than surgery. So let me show you a video here about how the balloon, so that the scope go down and the balloon goes next to the scope. We inflate the balloon with saline, and many times we add 10 cc of methylene blue. So when the patient eats, it will try to delay the gastric empty, in addition to provided, space-occupying lesion. In 6 months, how we remove the balloon through a needle, we suction all the fluid, and then with a grasper, we get the balloon out. So the procedure itself, technique is not difficult. The point is how to explain to the patient what is the procedure. Is the procedure the best for your patient or not? And how can you help the patient not only through the time of balloon placement, but through the 12-month of program. And I will talk about the details of this program in order for him to lose weight. A new balloon just been approved last month, which we call Obalone balloon. This balloon is CO2 filled of 250 cc, and this balloon does not require endoscopy for placement. However, you will need endoscopy for removal. It's CO2 filled of 250 cc. Patient can swallow one or more balloons and require endoscopy for removal. So the good part about this balloon, require only endoscopy for removal and nothing for placement. What about if we come up with idea for a balloon that does not require endoscopy, neither for placement or for removal? So this balloon is still in clinical trials. However, it's been approved in Europe. It's called Olarion. Require no endoscopy, neither for placement or removal. It has a thinner wall than the Orbera balloon, and it's filled with 550 cc of saline. It has a unique valve that release and open at 4 months, and the balloon then pass naturally as any gastric components. I have to point out that in clinical trials, they used ultrasound and fluoroscopy to confirm placement. However, down the road, they tried to avoid using ultrasound and fluoroscopy. And the last data I heard of, at least 100 patients had this placed in Europe, still to be approved in the US. In clinical trials, it's showing some promising data, 39% of excess weight loss, 10% of total body weight loss, 92% of patients were able to maintain weight loss at 6 months. So that's a very good number. And that's how it looks. That's the balloon inflated. That's the balloon before placement. And that's what the patient gonna swallow down to place or to have the balloon placed. What is out there in the pipeline, still in clinical trial, that we are looking at? SPATS balloon, which is a retention balloon, which is a balloon with a retention arm. And this balloon, people are working for placement for 12 months, not 6. And the other advantage, you can adjust the size of the balloon. You can, through the retention arm, you can decrease the size of the balloon or increase the size of the balloon through the course of 12 months. That's yet to be approved. There is transpyloric shuttle, which is not a balloon, it's a little device that in the fasting time, when the patient is fasting, it stays in the body of the stomach. While we're eating, it blocks the pylorus and cause delay gastric empty. Those are still in the pipeline and in clinical trials. So what about removing part of the food out of the stomach after eating? So this idea is a modification of a PEG tube. In fact, it's a 30 French PEG tube. We call it aspiration therapy. And it's called ASPIRATIC. That's an instrument that we use, approved in July of 2016. And basically, the patient will have a PEG tube placed with multiple valves outside, as you look here. And the recommendation is 20 minutes after you eat your dinner or breakfast or lunch, you are sitting in a restaurant, you go to the bathroom, open the valve, flush the stomach with liquid or saline, and then start to suction some of these nutrients out of the stomach. You go 5 to 15 minutes for 2 to 3 times a day. Doesn't sound good to go and have this when you are eating dinner. However, it works very good. Multiple people have used it. Studies had small number of patients, but it was very effective. They calculated 25 to 30% caloric intake were removed at the time of the studies. Patient has or had high patient satisfaction out of this procedure. And it has very limited side effects. It's basically a PEG tube placed in the stomach. So these are what we call space-occupying devices. What about gastric remodeling? What about using the same idea of surgery through the scope to decrease the size of the stomach or alter the surface or the anatomy of the stomach? Gastric remodeling. So we have a procedure. It's called endoscopic sleeve gastroplasty, ESG. And the same idea came from the gastrectomy, sleeve gastrectomy. However, using over a stitch, which is an instrument that you can go in the stomach and decrease the volume of the stomach. So it's approved for patient with BMI 30 to 40. It's an outpatient procedure. You can, if the sutures will break loosen or you lose effect down the road in a year or two, the surgeon or the gastroenterologist can go in and resuture again. It has actually more weight loss effect compared to the space-occupying devices, 18 to 20%. And it's irreversible after 6 weeks. And the technology has used already approved over the stitch device. So they didn't require FDA approval when it was started. There is another procedure in the pipeline, in the clinical trial. It's called POSE, which is primary obesity surgery endoluminal, and instead of having the whole stomach to be invaginated or decrease in volume, this idea is coming with where the most ghrelin is secreted. We know ghrelin is the hunger hormone that let us eat and let us feel hungry, and it's most secreted in the fundus of the stomach. So they said, what if we will decrease the size of the fundus? It will serve as decrease the amount of ghrelin secreted from this area, and also the fundus accommodate large amount of food at the same time. So it's suturing of the fundus applied to multiple suture, and it will end up changing the anatomy of the fundus from all this surface area to be a little banana-like surface area. This is still in clinical trials and still working in approval of this procedure. Before I go to the small bowel procedures, I want to point out that for the ESG, endoscopic sleeve gastroplasty, there were some side effects, side effect of pulmonary embolism. However, now for all the patients, they use DVT prophylaxis, and that's coming from actually surgeons' data about bariatric surgery. When surgeons do bariatric surgery, they keep those patients on DVT prophylaxis because they have higher incidence of deep venous thrombosis. Also, there was a single case of pneumothorax, and now they are using CO2 instead of O2 while doing this procedure. There was also a single case of fluid collection outside the stomach, which treated conservative at the time. So what about the last part of endoscopic bariatric therapy is small bowel procedures. These procedures are all in clinical trial. None of those have been approved yet. However, these procedures are targeting not only weight loss, but also they are targeting diabetes, type 2 diabetes. So we expect when those procedures are approved, they will be very, very helpful for patients with type 2 diabetes, even more than obesity itself. We have multiple procedures in the pipeline. However, I picked up 3 of those: ENDOBARRIER, self-assembling magnets for endoscopy, or some other people, they call it endoscopic anastomosis, enteral diversion, resurfacing of small bowel through ablation. But there are other procedures in clinical trials as well. So what is the ENDOBARRIER? It's basically duodenojejunal bypass sleeve. It's a sleeve that is made of Teflon, 65 centimeter in length, and you place out of the pylorus, and the idea is simple. It's try to bypass the food, bypass the first part of the small intestine into the jejunum. So when the patient eats, the food is supposed to pass all the way to the jejunum without getting any absorption in the small intestine. And that's where the idea at, and it's in clinical trial at this point. The self-assembling magnets or endoscopic anastomosis enteral diversion, it's actually a very unique idea. It's an iatrogenic fistula. What they do, one of the gastroenterologists will pass the scope to the farthest point in the small intestine, in the jejunum, for example, and another operator will do a colonoscopy, go from the other end, passing the colon to the small intestine, till they can see the 2 lights facing each other. And then they will deploy the magnet, which is an octagonal magnet, and those magnets will face each other from the inside, and it will create an iatrogenic fistula. It's basically close to the idea of biliopancreas diversion for weight loss, the surgery idea. And it will create another lumen that help the food and bile acid, mainly the bile acid actually, to pass quicker between the jejunum to the ileum, and it helps with weight loss and control diabetes. They use all cases in clinical trials are done with fluoroscopy, so you can make sure that those magnets are facing off each other without anything interrupted or entrapped in between. So that's the idea. So I talked about the three aspects of endoscopic bariatric therapy. So why shall we pick endoscopic bariatric therapy over all the other intervention? Minimally invasive. We have the balloons that it's like a quick EGD, 20-minute EGD, less morbidity and mortality. Complication rate are far less compared to surgery. And of course, it's more effective than lifestyle and pharmacotherapy. It's an outpatient procedure. There are a lot of data coming out about sequential therapy. What do we mean by sequential therapy? They have done a study about a patient who got a balloon. They lost weight in a year or two. For example, they went from BMI of 40 to 35, 33, and the patient wants to lose weight. So they placed another balloon and see how the patient is doing with this. And some places they use two different procedures. So you can use more than one option for the patient. And actually we are moving toward individualization of these procedures. Again, the same as what I spoke or as what I mentioned in diet, whatever suit me may not suit someone else. So that's very important to know. And the very important aspect, it can be reversible. We get a lot of patients, they had bariatric surgery, and after certain times, they are not happy with the procedure. What are the challenges? The big challenge at this point is reimbursement. It's all now cash payment. However, when you look to the total cost, it's far cheaper than surgery, but the patient still has to pay out of pocket. So that's an issue. The effort is growing, and in fact, all the gastroenterology society, in addition to the obesity and the endocrinology societies, are gathering together and trying to raise up their voice for the reimbursement part. Establishing a team, it's not an easy task, and I will talk about who are the members of the team in the next slide or so. And again, still we need to work more in individualization of the intervention or the procedure. Again, we need to reach to the point which procedure is better for every patient. So, the last part of this lecture, I will talk about comprehensive approach. Comprehensive approach, as I mentioned earlier, our goal as gastroenterologists is not to go in and put a balloon and leave the patient alone. It's not going to work. The patient will fail, the procedure will fail, and the patient will develop, an idea that whatever you provided me is not working. So here are the team members, and this team can add more members to the team, but that's where the majority of the places start with. Gastroenterologist, dietitian, you need a nurse, be aware of what's going on with these patients, surgeon, primary care, and psychologist. So what this team is going to do, and that's most important slide of my lecture, because this team is going to start with obesity assessment. Before we talk about placement of a balloon or what endoscopic bariatric therapy may be suitable for you, you need to start on lifestyle modification. You need to see the dietitian, and the dietitian will talk to you about diet, and also will set expectation, what we're going to do as an intervention for weight loss, after the procedure is placed, and after even the procedure, if a balloon, after the balloon is removed, how are we going to continue? We normally set for those patients to see the dietitian at least once before the procedure and once a month from now on for 12 months. Also, they need to see a psychologist before the procedure and once a month throughout the 12 months program. Sometimes they may need to see the psychologist even afterwards. Exercise part, in some programs they have trainers for those patients to work with them and help them out throughout the obesity assessment phase. So once we set up the expectation with the team talking to the patient, we go into the weight loss intervention. Everybody must have lifestyle modification. And then we'll choose between pharmacotherapy, endoscopic bariatric therapy, or surgery. After the procedure is done, weight loss maintenance is very difficult, very critical phase for the patient to maintain the weight that he's going to lose and not to relapse. And after this phase is completed, which is by the end of 12 months, patient need to work on weight regain prevention. And that's also part with talking to the dietitian, talking to the psychologist in order to have behavioral therapy for these patients. So where are you at LSU in Shreveport? Or where are we, in Shreveport? We don't have a weight loss program in town. There are 3 surgeons in town. They do surgeries. One of them actually is placing some of the balloons sporadically. I'm currently in our section working with the administrators as well as NITIN in order to establish the program. We took quite a few steps, and hopefully we can get University Health as well after all the issues are over to start the program here as well in Shreveport. The last thing I would leave with you, what Albert Einstein mentioned, the measure of intelligence is the ability to change. And we need to change the 35% prevalence of obesity in Louisiana. That's very important to do. With this, I conclude. I hope I caught your attention about this endoscopic bariatric therapy, and I'm ready for any question.
So what's the mechanism, if you take the balloon out, what's the mechanism by which that procedure continues to have an effect on maintaining weight loss?
So, as I mentioned earlier, the main goal of the whole idea of weight loss is to work on the lifestyle and, more importantly, to have a behavioral change. So if I do well with weight loss, with my diet, with my exercise, but still my thinking is not changed, I will not accomplish anything, and it will be the same. So that's why we always, our programs now, we send those patients to psychologists in order to achieve behavioral change. Because knowing from all the studies done in the past that diet and exercise alone, they will help, but they will not accomplish a big change. What the endoscopic bariatric therapy is going to do is going to move the patient from 0.8 with a BMI, for example, of 40 to a BMI of 34, 32, and now you lost this amount of weight. Now you're part to work on behavioral change, behavioral therapy to keep this weight loss. And that's why we recommend to start early on. We do not start at the end after removing the balloon or after the weight is lost. No, we start from before even we place the balloon. We set the expectation with the patient. We send this patient to see psychologists.
So the data you showed with the balloons on how much weight loss, was that at the 6 months when you move on that on what percentage of patients keep going off at the balloon?
So those who were at 6 months, as I mentioned, was reshaped balloon. They had a data of 66% maintains a weight loss over 12 months with aspiration therapy, which is a modified PEG tube. They had 92% maintains a weight loss in 6 months. So it's promising data out there. No, all these balloons were approved. First one approved in July 2015. So still the data are new for the US. However, from European data, it's promising. But again, even in the patient who accomplished some weight loss, but still did not go below 30 BMI, we can use another procedure, another balloon or something else.
I would just point out, 1 year is not a long time after removal of balloon. We know most interventions, dietary, pharmacotherapy, patients lose the plateau, and a year or two later they're regaining. And it's often not till a year to 2 years out. So I think the data is short-term right now. The other is that the data, I'm assuming, are all from clinical trials where there's this whole team approach. And my concern is when and if this gets translated into real-life practice, what really are going to be the outcomes? You know, I can understand your group having a very organized approach, multidisciplinary. But when it gets into general practice, what's really going to happen? Are all the ancillary activities that need to be associated with it really going to happen? Or are people just going to throw balloons in for 6 months?
And also that gets into motivation of the patient that keeps following health problems of people. And a lot of patients have lost their weight and they don't want to keep coming back and forth. So I think that, and in the study, those people might have been already sensitive. So I think it is interesting.
These are very good points. And as what you mentioned, the data is still very early in the US. However, I point out to read the data from out of surgery. So because the bariatric surgery have been there for long enough, there was a very big study presented in 2012 in JAMA. They pointed out all the patients out of bariatric surgery and over 10 to 20 years data, and good number of patients were able to maintain the weight loss. However, we have to put out that the surgery is irreversible. These procedures, some of these procedures are reversible. So there are good data out there of bariatric surgery. It's short term for us as gastroenterologists. All right, thank you so much.